Hello, everyone. Welcome to SimiTree's webinar. We're really glad you guys are here today. We're going to give everybody just a minute to get into the room. But as you guys are joining, if you have questions or need anything while we're going through this presentation, please don't hesitate to put it into the chat or the Q&A. We will be sharing the handout here in just a minute as everybody gets in and gets joined. My name is Missy Gilliland. I'm the Learning and Development Director here at SimiTree. We're really glad you could join us today for our webinar on safeguarding the front lines. This is a great webinar to learn about how you can protect your teams, really share some good information from some of the experts in the field. I will be sharing the handout here in just a minute. If you have any questions, please don't hesitate to put them in the chat or the Q&A. We're really glad you could join us today. With that, I'm going to turn it over and hand it to Melissa to get us started.
Great. Thank you, Missy, and welcome, everyone. Thank you for joining us. I'm Melissa Gordon, Senior Manager on the Operations Consulting team at SimiTree. I'm a registered nurse by trade, and I've been in the industry going on a couple of decades now and have experience in all areas of home health, hospice, and private duty, including field, quality, and an operator. So I'm happy to be here, and I'm joined with Kathy, and I'll turn it over to Kathy.
Hello, everyone. I'm Kathy Dettling. I'm the Vice President of Clinical Strategies at AFIA, a SimiTree company, and I spent about 26 years in the behavioral health field before spending the last 10 years here at AFIA as a clinical consultant. And a lot of the work that I supervised, that I managed, were community-based workers. I'm a master's level psychologist by trade, and I'm really happy to be able to provide this information. So just an overview of the objective. Our home and community-based workforce provides such an important part of our recovery supports. And in that, we wanted to have this webinar to be able to provide some education on the risks and the strategies that ensure not only our workforce safety, but also the safety of the people that we provide services to. And what we're really looking at is a complete expansion of community-based and home-based supports and services across the entire healthcare continuum. Historically, what we saw were rehabilitation and treatment services were primarily facility-based. But over the course of the past 30, 20, 10, and even 5 years, we're starting to see really a blossoming of community and home-based services and supports that really help meet people where they're at and help bring treatment and services so much more easier to the folks that we're working with. And what we're really seeing is that home and community-based supports have really is expected to grow by at least 25% over the next 10 years, which is a much higher growth rate than any of the other occupations. The different types of supports that we're seeing is end of life supports and services through hospice and home health. We're seeing a lot of private duty and longer hours of care. We're seeing a lot of supports and services that are set up for physical health and recovery management, or if somebody has an injury or accident as part of that rehabilitation and recovery, where historically folks may have had to stay in a rehabilitation facility or a nursing home in order to move through that recovery journey. Within the mental health continuum, we've had mental health supports and services for well over 40 years, but primarily it stemmed from people stepping down from inpatient facilities or residential facilities and moving into the community. What we have now is an expansion of those supports and services at the time that people begin to be symptomatic, so they never need those higher levels of care. And we're seeing more and more community-based supports and services so that people with developmental or intellectual disabilities can move out independently and live on their own so they can live their fullest life possible. And in the last couple of years, we're seeing more and more substance use supports and services being provided within a home-based environment, including medication-assisted treatment, combined with a lot of the telehealth options. And what this expansion really does, it eliminates a lot of the barriers into recovery-based treatment. We're seeing, when people have barriers with transportation, if there's a lengthy distance for people to go to treatment, people may not engage in treatment. And we're also seeing mobility issues being assisted with having home-based supports and services, but really oftentimes quality of treatment. So you don't have to go into the office to provide some of these services that can be more easily and emulated in your home. And with the overall goal of really meeting people where they're at and really trying to make sure that the recovery journey is successful.
So let's talk about some of the fears first as to what we possibly see when we go in. And in saying that, to care first doesn't mean ignoring the risk. And we do have many areas of risk as we go into an uncontrolled environment. And we're going to talk a little bit about that. But we have to really be prepared and we have to be focused. And why is this? Because we know that the best estimates are there have been about 15% of community-based providers have occurred an experience of violence. And also approximately 50% have incurred verbal abuse. And that's most likely underreported. So it's really important for us to be aware, be mindful, and put in some strategies. And I'm going to go over the risks first, and Kathy will go over the strategies, and then we'll tie it all together. But, the importance, as Kathy mentioned, the growing area of community-based care. So to care first really means, we want to be aware of where we are before we walk into the home setting. So one of the first areas that we want to talk about in the predictors of risk is fear. And a huge assumption that we've all had, I know I've had being a field clinician, is that everybody welcomes us when we go into the home. When in actuality, we've got, some that are very fearful, but maybe others that are more comfortable with us working, coming into their home. And there's a fear of judgment. I've even had those experiences, my house is very dirty. You can't walk in, am I going to be able to comply with what you're telling me to do? There could be a loss of independence, meaning you're coming into the home, but I can do all of this anyway. I don't know why you're here. The fear of possible removal. And then that fear of, is there ever going to be an unannounced or unplanned visit of you coming into my home? And those put us all at risk when we're thinking about that because of the way that the patient or the client is perceiving us coming into the home. So we need to be aware of these fears. We also need to be aware of the external factors of why we're coming into the home. Is it by a guardian or a parent request? Maybe they're trying to connect with their teen, they're having a hard time. Maybe they're trying to connect with their elderly parent. It could also be caused by an involuntary treatment from a mental health court order or an order of the justice system. So again, not only fear, but then there's motivation of an external factor as well. And then the threat of removal. We've had certain circumstances where we're brought in because of that instance. That causes risk to us as well. So again, being prepared, and how are you going to construct a good strategy for something that is unknown when you walk through the door. The control over the environment. We know those of you that have worked in an institution setting, say an acute hospital, mental health facility, that there's usually all kinds of signs and posters of visitor expectations, what you can and can't do when you walk through the door. We saw a lot of this change when we incurred COVID, but when we're walking through the door of someone's house, it's a lot different. And we all know this, we're all aware of this, but things have changed quite a bit over the years. So, and we look to that because we look at what's changed in the institution. So they're gone are the days, right, where you're able to walk up to the patient's room. Gone are the days, a lot of the times, where you can't even walk into the doctor's office without calling first. So we want to be, again, very aware of what we're walking into and making sure that we're communicating effectively, because we don't have this lovely graphic in front of us when we go to a client's house or a patient's house that says 1 visitor or 2 visitors and all of the other restrictions if you're sick or not sick. So we do have to be very aware of that. And then, unfortunately, we've had a lot going on in our country that also poses us at risk. And when we think taking a step away, when we think about what's been going on in the country, I think a lot of us can make a list that is concerning, and even concerning for those on the call now. We've got a lot of political divide that's possibly impacting families and communities. And we can think of this when, again, COVID came and it was mask versus no mask, vaccine versus no vaccine, and it caused a lot of strife between communities and families. Highlighted in the national news is weapons and guns, the right to bear arms, and we've all been trained on a lot of this, but again, this has come to the forefront. The bullying and the demeaning of people in different races and cultures. A lot of us are trained in cultural sensitivity and making sure that we're, not being biased, we're not bullying. We understand all of that, but again, we're walking into that uncontrolled environment, and what are the right questions to ask, and how do we manage those situations when we're in the home? The obsession with the facts on social media. We know that social media has consumed a lot of what we do in our life. We've also have been educated on fake news, where to get our news from, and really what is the truth. So we need to be aware of when people bring up certain topics and conversations. Is that true? Is that not true? And then the vulnerable adults and all of the they're a target and they're being scammed. I know I've had this own conversation with my own parents. They can take your voice and they could seem like they're you and you need money. And how do you manage that with adults? And this can even be drilled down to when you call to make the appointment. Do they know it's you? How do they know it's you coming to take care of them? So those put us at risk because they're really unsure. The client and the patient could be unsure about who we are and what we're there to help them with. So again, to be mindful of that. So I'm going to hand it over to Kathy to go over some of the strategies to mitigate our risk.
And we'll start first with some real general safety strategies. And these are things that you should do to prepare your workforce. The first thing is have a training on risk. And it's a fine line between over-responsiveness and under responsiveness. There may be this idea that when you're going into an elderly person's house, that there's very low risk versus going into a home where there may be somebody with a serious mental illness, and that may be a high risk. But that's not necessarily the case. In my experience, working in the behavioral health field for all these years, there was more riskier situations that happened within the building than what had ever happened to any of our community-based workers. And that may be a rarity just for the agency that I worked with, but we also found that that doing some general safety strategies ahead of time, all of our community-based workforce really kind of did some pre-planning in order to mitigate any of the risk. And so we want to make sure that we don't scare workers during the safety training, but really just to create that overall awareness. The first thing always is to have a cell phone. And again, I did community-based work during the days where there was no cell phones or there was no coverage area. With these days, community and home-based workers have a cell phone. There is a Find My iPhone tracker that can be easily turned on if you're going to an unsafe area. But as a home-based or community-based worker, always have an awareness of what the coverage limits are. You know, when I have conversations with care managers or home-based workers, there's always a great awareness that if you go into a certain area, your cell phone won't work as much. And they take precaution as they do that, just to make sure people know where they're at. Another way is to having a shared schedule. And for many agencies, home-based workers are a little bit leery about this because they think maybe somebody's checking in on them. But really having a shared schedule really helps the overall management of when people are checking in and when people are checking out. So you can have awareness of where your workforce is at any time in case of an emergency. And as part of that, if there's any unplanned contacts, with it may be that a healthcare provider has to go in at midnight and do an unplanned check, making sure that there's somebody that is aware that your workforce is heading out into an area at that point. So always having awareness of where your workforce is and what they may be doing is important. Pairing up, especially like with my history in the behavioral health world, if we were going to go to do an initial home visit where we understood that there may be some risk involved, we may send a 2-person team just for that initial contact, just to make sure that just in order to assess the risk. Or if the call is an emergency basis because somebody's symptomatic, having an additional person pair up as part of that contact may be something that as an agency should be the expectation. Sometimes it's more difficult with coverage issues, but having that backup or somebody that can do the dual person check may be helpful. And lastly, we encourage our home and community-based workforce to really come into the home or the community with minimal baggage. And I know that may seem contrary to oftentimes agencies having collateral documentation or current documentation standards, but having your phone and your cell phone and your keys in some sort of an old-fashioned fanny pack or a very small bag so that you're able to exit a situation fairly quickly as needed. If you're going into a higher risk situation, it's okay to leave your laptop in the car and lock it up until you can better assess the situation. So if there's a known risk, go in with the minimal requirements. If for first contacts, as you're scheduling contacts, you want to do a lot of prep planning ahead. I like to put in place an introduction call so that the person that I'm going to be working with has a good understanding what to expect. It also helps me as the home-based workforce to understand what I can expect walking in. I want to know about who lives at the home, who may be at the home during the contact, because oftentimes some of our safety risks may not be coming from the person that's receiving services and supports. It may be from a visitor or relative or somebody who's in the home unexpectedly. The other thing that we like to talk about is pre-assessing any potential risks. And that's asking about weapons without making any judgment about whether people should have guns or not have guns. We can make a blanket statement saying, are there any weapons? Are there any firearms in the home? And if so, during our visit, we really ask that people keep those locked up and out of the way for the safety of everybody involved in the contact. And again, without judgment, just putting it out there about the risk. The other thing that we do for that safety first is really get a description of the home and ask where a good place to park is. You know, some of my early home-based appointments, driving around and trying to find a safe place to park, especially if it's an evening appointment, there can be a risk if you're walking through a neighborhood and having a far way to park. And so as part of the environment, you really want to make sure that it identify any risk to self. So does the person have a history of depression? Does the person have any risk, any history of harming themselves or harming others? And I think that sometimes there's a little bit of a concern that asking about suicide or asking about self-harm gives people ideas to do that. And that's not the case at all. So doing that good environmental risk assessment prior to starting to services, and also identifying any possible vulnerabilities. You know, is there any risk of violence by others? Is that person, as Melissa said, is that person at risk of being taken advantage of by other people? Is that person risk of being controlled by other people? So your environment, the environment that where people live can help us identify risk. And a good tool that seems to be systematically used across the behavioral health, home health, hospice, rehabilitation sequence is the social determinants of health. You know, the more challenges people have with social determinants of health, the more questions that we would have about environmental risk. Okay. And so when you're doing outreach contacts, so this may be a first contact with a person, you want to review that information very thoroughly. Again, historically, home-based, community-based care generally happened when somebody was in a facility environment where all the rules were in place and they were stepping down. So you had a whole lot of information about the person of what their needs are, with the focus being maybe diverting people from those higher levels of care and doing rehabilitation or symptom management in the home. The referral information may not be as complete as it was once. And so reviewing that information thoroughly and during that pre-call, asking those questions is really important. The other thing that we want to really make sure is, you know, ensure that all general safety strategies are always practiced. Just because things were safe for the past 2 months and there was no issues doesn't mean that something has changed within that person's environment. There may be a higher level of medical pain going on. There may be an exacerbation of symptoms. It may be a really, really warm day and the air conditioning is out and everybody is irritable and it may become ugly. So always ensure that your general strategies are always in place. And then again, the first thing that, you know, that we do is as we arrive, we always assess risk, and that is a priority. We look around at our environment, we look at what's happening in the home, and, you know, and if there is anything that's out of the norm, we have to take note of that and make sure that we are reacting to that. You know, a lot of that is all about trusting your instincts. You know, if the person has animals, you know, and the animals may not be friendly. We want to make sure the animals are, you know, are safely in another place. So that assessment of risk is really a priority for what we're doing. And then, you know, and again, the general safety strategies is really making sure that that a good assessment and ongoing assessment of the person's support system is in place. Again, who lives at the home, who visits the home, who may be popping in and out of care, and identifying if there's any risk involved with that. And oftentimes with community-based or home-based appointments, you know, we ask ahead of time that for privacy purposes, that minimal people are at the home during the contact, if that's at all possible. But remember, as Melissa had indicated, when we go into somebody's home, the rules are their rules, they're not our rules. And we as the provider can't restrict who comes in and out of that person's home. Another thing to look at is home safety and structural safety. You know, some of my most scariest moments as a home-based worker is when I was doing contacts in a home where there was holes in the floor or appliances weren't working. And when I would be aware that was happening, that was happening, part of my role as a case manager was to help address those needs. But I also may pull the contact out into a porch or the front lawn or some other area where I can be assured that the contact can happen safely. And also being aware when you're going into the home of what are some of the exit routes instead of in case something happens within the contact that puts you at risk. You know, knowing what the exit routes are. If treatment or supports or services are being provided, having it as close to an open exit area as possible, if at all possible. You know, but if treatment is being provided at a back room in the corner, just be aware of your exit strategies in case risk happens. The other thing is making sure of your neighborhood safety. You know, understanding your routes going in and out of the neighborhood. Again, making sure that you have the parking downtown. And if at all possible, keeping your visits to daytime visits in areas where there may be a little bit more risk. So in the moment interventions, again, having that brief assessment at every contact. Again, providing those supports and services in an area of less risk. And if there is some elevation going on during the contact, you want to make sure you give the individual or family space. And of all things, use your de-escalation skills. If you are walking into a situation where something feels really uncomfortable, I think the big thing that we want to do is make sure that you trust your gut. You know, walk out, say that you've forgotten something, leave the area. So to make sure that you don't continue in the moment under the guise of care first and worry about the risk later. Because again, the most important is to trust your gut. But when that happens, make sure you report it, you know, because as Melissa said, a lot of what has happened is often underreported.
Right. Yes, Kathy, and I love how you mentioned just, you know, really being able to have that plan to go out to say, you know, my plan was always, I forgot something in my car. And you turn around and because, you know, my gut was telling me that wasn't right for me to be where I am. So continuing on off of Kathy's strategies, the overall plan, you know, prior to the visit is to be prepared. So like Kathy mentioned, look at the referral information, know a lot about where you're going, your exit plan, meaning I was trained to park my car so I would be able to get back in it and leave. Not that I would get blocked in the driveway, or I knew where my car was. It wasn't going to be towed if you work in a city. So be prepared, you know, put on your thinking cap and just making sure you have everything covered. When you're in the visit, assess for safety during the visit, making sure you're looking for certain things, following your company's policies. So is it to put the dogs away? We want to communicate that prior to the visit. Is it no guns, drugs? Your safety is a priority, and the safety of your client and patient is also a priority. So making sure you're assessing that during the visit. After the visit, review your safety concerns. Did you have any? You know, maybe there were a few dogs that they had in the house. They were put away, but making sure you communicate that to your supervisor or a note that the next person going into the home will see, you know, has dogs, making sure that you communicate you're coming and put them away. Creating those safety interventions like that, for instance, in an ongoing plan. So if you didn't feel that it was safe to be there, maybe there is another option for you to meet the client and patient, but making sure again that those safety interventions are ongoing. And you could even take that outside of the workforce safety and making sure that there are, You know, we do a whole safety check, as most of us know, being community-based providers. Are there fire alarms? Are there, you know, smoke detectors, those kind of things? And then when you're done reviewing your pre and your post plan and your interventions, if there were any concerns, did you report them? And that reporting could mean, you know, a variety of entities, including your own company reporting. And then is it necessary to report to the state? So being very mindful, but having that plan is like, and as Kathy mentioned before, that plan is a priority for you when it comes to safety. So there are some resources and guidance, very good ones that most community-based providers are using right now, and that's always to go to OSHA. OSHA has trainings for community-based providers. The Joint Commission, also in conjunction actually with OSHA, has some great safety tips. And then those of you in home health and actually other organizations, if you're a CHAP provider, they do also provide training on employee and patient safety. So we'd like to thank you for attending today. I'm going to turn it back over to Missy. And if you have any other questions or concerns, actually, Missy, are there any questions before I?
Nope, I don't see any questions, Melissa, but as always, if you have questions, please don't hesitate to reach out to us. We will be sending a copy of the handout and the recording to you, so you have that for future reference. That usually comes out about 72 hours or so. With the holiday, it may take a little bit longer, but it will be coming out to you. But if you need anything, reach out to us. We really thank you for your time and attention. It was great to have you guys join us today. Thank you, Melissa and Kathy, for a wonderful presentation. Everybody be safe out there and have a wonderful holiday weekend.
Thank you.